This is our last. This is our last group presentation. As the part of last group, the topic also which was end of life care. Some screens are shared, ma'am.
Actually, it is showing our face. So, could you please open that PPT?
Shall we start, ma'am?
Yes, ma'am.
The outline of the today's presentation was introduction, case scenario, discussion with questions, video presentation, conclusion, takeaway home message, and teaching strategies. What this picture depict? I think many of you might be seeing this picture and also the video. This is the last 2 months the internet and also the all the social media has been flooded with the image of the little monkey holding on tightly to his orange orangutan toy, carrying it everywhere and cuddling it for warmth and comfort. This is the story of Punch, a baby monkey which was born at Ichikawa City Zoo in Japan and abandoned by his mother shortly after his birth. Punch was left alone, and no one of other monkeys thought to accept him. Caregivers of zoo gave him an orangutan toy. Thereafter, this one inanimate toy became Punch's mother and companion. The story of Punch is more than just a viral movement. It mirrors our own human experiences and how presence matters, especially in end of life care. So the end of life care, the scenario which we got this for the presentation was Mr. Das is an 80-year-old man with advanced lung cancer. He has previously undergone chemotherapy and radiotherapy, but his condition has continued to decline. He is now in a deteriorating phase, sleeping for most of the day, speaking only a few words intermittently, sipping just a few teaspoons of water. He is less responsive and terminally ill. One evening, you receive a call from his wife. She is very anxious and reports that Mr. Das is having noisy breathing and increasing unresponsive. Concerned about his poor oral intake, the family requires the insertion of a rice tube to provide nutrition and fluids. The questions which was given to discuss: what is the most likely cause of secretions at this stage? What will you do? What nursing care should be provided in this situation? What should the nurse do based on ethical principles? So, based on the clinical assessment, the signs of sleeping most of the day, which indicates the Mr. Das is in active dying phase, and he spoke few words with less responsive, which indicates he is in the neurological withdrawal, and he sips only teaspoons of water. So this shows he is naturally deteriorating his normal physiological functions. Noisy breathing, which is death rattle due to cooling of secretions, which also signs that he is in the end stage, and increasing unresponsiveness, that is shows he is in an imminent stage of death. Before going to see that, let us just review the signs of dying in the three phases. In the early phase, the patient will experience decreased appetite, difficulty in eating or drinking, and he feels fatigue. In the stage of middle, due to poor circulations to the peripheral areas, the patient has the mottled skin and cold peripheries, especially in the hands and feet, and he becomes more fatigued and limited or no speaking or moving. So activity limitations also will be there. And in the late stage, he will be restlessness, disoriented, and changes in breathing due to the altered mental status. And in the final stage, the patient will shows the incontinence due to relaxation of the muscles. So now this Mr. Das is in active dying phase, is in the final stage of life, typically lasting a few hours to 3 days, marked by profound physical, emotional, and behavioral changes as the body gradually deteriorates. Let us see through the one video.
Talking about dying can be very difficult, and people often avoid the subject, but it's a part of life that we will all have to face. As the end of life approaches for a loved one, it is understandable that you may feel apprehensive and have many questions. This video should help you to understand, anticipate, and respond to some of the signs you may notice. The first sign you may notice is decreased appetite and thirst. A common reaction is to want to begin using supplements and intravenous nutrition with the idea it couldn't hurt. But research now indicates that the use of forced nutrition in terminally ill patients may actually worsen a patient's condition. Let me explain this. The digestion of food requires a level of energy that a dying person may just not have. One way even a healthy person may have experienced this is a growing nauseous feeling or even vomiting following an intense workout. During an exhaustive workout, the body reallocates resources such as blood and energy to the muscle groups and organs that require it the most. This leaves the digestive system with limited energy, thus frequently inducing nausea because it is unable to process the food at that moment. A dying person's body is also reallocating limited energy supplies to keep the essential systems of the body working. Because of this, their bodies lack the strength to digest food, thus making the presence of that food or fluid painful or even intolerable. Most of us can hardly imagine going for more than a day without eating. The dying, however, typically do not experience discomfort associated with not eating or even dehydration, besides possibly a dry mouth. Once dehydrated to a certain degree, the brain frequently releases endorphins that block many pain receptors, a kind of built-in painkiller system. Artificial nutrition, on the other hand, can induce a form of false hope for the body, allowing it to continue to fight to stay alive. Painful, hopeless fights that typically only prolong the dying process. In the days before a person dies, the heart is no longer able to pump the blood effectively throughout the body. In an attempt to preserve oxygen delivery to the brain and heart, blood is shunted away from the extremities and non-vital organs, such as the feet and hands. This may lead to cold and mottled extremities, from where it then travels up. It is not painful, but giving the patient an extra blanket may help keep them warm. Research shows that this occurs late in the dying process and is a cardinal sign that death will occur within hours to days. The third sign you may notice is a changed breathing pattern. As the body is dying, respiration progressively becomes a solely involuntary act controlled by the brain cell. This means that the breathing pattern is reflexive and no longer a response to conscious awareness. Breathing becomes less regular. There might be periods where a person may not breathe at all for as long as 10 to 20 seconds. They are not a desire or hunger for air, but rather a basic reflex of the dying brain. This final or agonal breathing pattern is also called fish out of water breathing. It is an ineffectual gasping of the mouth with little or no actual air intake and signifies that death is very near. On top of this irregular breathing pattern, you may also hear a kind of gurgling sound every time the patient breathes. This is because swallowing becomes more difficult and secretions may pool at the back of the throat. These accumulated fluids may cause a noisy breathing that is known as the death rattle and sounds like this. You also may notice that a dying patient sleeps a lot. This can be distressing for relatives, but it's important to understand that physical exertion for someone approaching death is exhausting. And for the moment, all effort is being put into staying alive. Nearer the end, the patient may transition from sleeping many hours to diminishing consciousness and then coma. The fifth and final sign is incontinence. When we're alive, our brain is constantly sending signals to tell different parts of the body what to do. At the end of life, these signals stop and our muscles relax. The bladder and the sphincter are in a constant state of contraction, so when there are no more brain signals to the bladder or bowels, they will relax. And this is why it is not uncommon just before or after death for incontinence to occur. Thank you so much for what.
So let us, and we have understand the signs of dying. So now we started our topic, what is the end of life care? So which is care provided in the final weeks, days or hours of life when curative treatment is no longer beneficial. Mainly we are focusing on comfort and dignity of the dying patient. The goals of end of life care: to relieve suffering, to manage symptoms, and also to support psychological and spiritual needs of both patient and family and enable a peaceful end. Here we are using a palliative approach, mainly shifts focus from aggressive intervention, that is curative or restorative treatment, to quality of life, that is comfort of care, mainly to relieve pain control, emotional support, and family guidance in the way of family counseling, and also for bereavement process. Here we are seeing the phases and layers of care of palliative. Here the ends of life care, which also involves ongoing medical treatment, which is appropriate and including the home support. And here the main focus is on non-curative, that is a focus of comfort. And end of life care, which lasts from weeks to months. And mainly here we are focusing on symptom management, focusing in all aspect of WHO health aspects, that is physical, emotional, mental, social, and spiritual, all aspect we are covering here, which also includes the team of multidisciplinary nurse, physician, volunteers, social healthcare workers, bereavement counselor, and hospice people, and physical therapist. And for spiritual needs, we are including the chaplain or other concerned religious persons. And main focus is on patient and also the friends and family, and we are involving the caregivers. Here we got the 4 questions. The first question is, most likely cause of secretions or noisy breathing is mainly due to, we have seen death rattle. Why this death rattle is happening? This is nothing but it is a sound which produced in the when the patient is breathing. So this is also called noisy breathing. So this why it is happening means the accumulation of saliva and bronchial secretions which will take place in the upper airway, because here the patient loses the ability to swallow and cough. So this reflux is lost. So the patient unable to swallow the secretions. So these secretions will get accumulate in the upper airway. When the patient breathes air, so the air which flows through this accumulated secretions, which produce the sound called rattling or gurgling noise. So this we are calling as a death rattle. One thing we have to be insist on family members, it won't distress the patient because the patient is unaware of this symptom. Only this will be distressing to the family. The family will be assuming that the patient is having pain or choking, or patient is having breathing difficulty. So this won't cause anything to the patient. So this we have to make insist on the family members. And this death rattle is a sign of active dying phase. So here we can able to understand that patient is in the phase of active dying phase. So within hours to days of is near to death. So, and also here we have seen that patient is having lung cancer. So the contributing factor is the lung cancer, because normally this normal secretions will be cleared out through the lung systems, respiratory systems. So this mechanisms will be affected due to this lung cancer. And also the patient is in the terminal phase and in the end stage of life. So his reduced consciousness also will be eliminating the protective reflexes like swallowing and cough reflex. So this will causes the death rattle. So the only thing you can able to acknowledge the family members to turn the patient to one side and to relieve the secretions. Only we can able to raise the head end of the patient. The second question is, what will you do for the Mr. Das? So one thing, after hearing the phone call from the Mrs. Das, you have to respond very calmly and in the sensitive way immediately. And immediately you have to visit Mr. Das' home, and you need to perform a full immediate assessment. What is the problem of the patient? How he is breathing? What is the respiratory rate? What is the pattern of respiration? And how he is having the responsiveness, and what is his comfort level. A pain assessment you have to do it, and you have to find out, is there any signs of distress present for the patient. And next thing, you have to reassure the family, especially the Mrs. Das. You have to explain very calmly, this noisy breathing is a natural part of dying process and does not mean that Mr. Das is choking or in pain. So he is not aware of this, what is happening to him. So these things you have to make the patient to family to understand. And for this, you can position the patient. So you have to inform the Mrs. Das to keep a patient in a lateral position, or to raise the head of the bed to 30 to 45-degree angle. So this gravity will helps to reduce the pooling of secretions in the airway. So this we can able to advise to the Mrs. Das. And if suppose the patient is having any dyspnea or labored breathing, we can use the hand fan, or you can keep the fan just in front of the face, not distressing, mainly to relieve the air hunger. So this can help the patient to relieve the hair hunger. And the next one, what you can do, you can here the mouth care is very, very important. Oral care is very important. Because secretions are present, so you can provide gentle oral hygiene. So you can advise, or you can inform the family member to use a moist swab, cotton swabs, to clean the oral, especially the lips, mouths, and oral gums, teeth. So all these things areas can be cleaned very gently. And suctioning, it is very rarely you can do the suctions, only oropharyngeal suctioning if it is distressing or secretions are more. Otherwise, the deep suctioning can be avoided in this case. And coming to the pharmacological management, as per the doctor's advice, physician order, you can use the anticholinergic medications, because this will reduce the secretions. Glycopyrrolate will reduce the secretions. And if the patient is having, the main problem is pain, so you can continue the pain assessment, and based on that you can ensure the opioids are continued, and it should not withhold any pain medications. So this is regarding the pharmacological management. If suppose patient is having any agitations and delirium, so you can give midazolam and haloperidol based on the doctor's advice. And regarding the Mrs. Das has enquired regarding the NG tube request. So this request, gently and sensitively, very calmly, you can discuss with the family that inserting Ryle's tube is not mandatory at this stage, because giving nutrition does not prolong the life of the quality of the patient. It doesn't improve the quality of the patient. Further, it will deteriorate the patient conditions. So this you can able to calmly you can explain, and to not to insert the NG tube request. The next, I will hand over this to Mrs. Abhishek ma'am. She will continue this one. Abhishek?
Ma'am, am I audible, ma'am?
Yes, dear.
Ma'am, I'll continue, and thank you for the opportunity, ma'am. So the third question for our scenario was like nursing care in this situation. So as ma'am discussed, what will we do in the second question? Same thing. Along with the these management, nurse play also the role of a informer or an advocate for the family member. So in nursing care in this situation, as we saw, for the physical comfort, we will be concentrating on the positioning of the Mr. Das. So every 2 hours once we will reposition him in order to prevent the pressure ulcers. And then, as discussed in the oral care, we can do the oral care so that we can use the mouth pads which are soft and foam, and every 2 hours we can give to keep the lips from drying. We can use lip balm or oil can be applied. And then if Mr. Das is having any dentures, we can also remove the denture, and we should not force anything orally for the patient. Next is the skin care. In physical comfort, we also concentrate for the skin care. So here we can use barrier creams, or for incontinence care we can use diapers. If patient cooperates and the family members cooperate, we can insert a catheter. We should not even force for that. And to maintain the skin integrity, again we can use any moisturizers to keep the skin in a normal way and from preventing dryness. Next is the symptomatic management. So here we can administer medications for the pain. So the patient might be on any opioid analgesic, so that can be continued, or any SOS drugs which he is already on, or as a to relieve the pain, we can give the SOS drugs, and that also should not be in the oral route, but we can prefer any other route like subcutaneous route can be followed. And in order to see for the to reduce the secretions, here ma'am had discussed anticholinergic medications can be given, so that will be preventing the secretions to be pooling in the throat. And then monitor for the signs of discomfort. So this, it will be like a non-verbal communication. So by seeing his face for the grimacing and restlessness and irregular breath, these are the signs of discomfort. So through these signs, we have to manage them symptomatically. Not only physically and symptomatically, the environment in which Mr. Das is, we can maintain the environment as a calm and quiet. The loved ones can be near him as a support for in the last stage, and we should also ensure the privacy and dignity at all the time for the patient. Next is the family support. So uh, in this condition or in this phase, the family members will be in a uh, pathetic, or they will be worried. So we have to explain them regarding the signs of dying process and encourage them to speak softly to Mr. Das. And as we know, in the senses, the hearing is the sense which will be present till the last. So here they can speak with Mr. Das to have a peaceful death and facilitate the presence of loved ones. So in that room, we can ask his loved ones to be there. Next is the emotional and spiritual care. So here, though the family is in a grief stage, we have to give them the emotional support, as well as spiritual care is we can ask the family members, they can have prayers, or they can have a slow music, all that in a spiritual manner. They can give the spiritual support also to the family and the patient. On doing all this, the main part is the documentation. So here we have to document all the observations, what all we have done, what all the family members have clarified. So each and everything we will be documenting in a accurate and prompt manner. Can I have the next slide, ma'am?
Yes, sir.
So here the again not only the nursing role, the family also plays an important role. So next, while doing all these cares, we also should have in mind the ethical principles, or what are the ethical issues which might arise in this stage of dying phase. So here we concentrate on 6 ethical principles, likely the autonomy, beneficence, non-maleficence, justice, veracity, and fidelity. So when it comes to autonomy, autonomy is every individual has the rights to make a decision. So here, Mr. Das, as a nurse, we can ask, did Mr. Das have any wishes, or has he expressed about any wishes to his wife or his son regarding the advanced directive living will or something like that? If he had, we can ask that. And then if even if the baby, even if the Mr. Das is in the unconscious state, this we can apply. And if the Das didn't have any will like that, before we are taking any decision or final decision, we have to involve the family members before deciding the final decision. So informed consent of principles is to be obtained. Next is the beneficence. Beneficence means acting in the patient's best interest. So here we should focus only on the comfort of the patient, whatever gives comfort. So as we know, end of life care is shifting from cure to comfort. Here, though we know NG tube or insertion of any tubings will help for the patient, here we have to mainly consider the comfort of Mr. Das. So the family member in this scenario, the family member had asked, since he is very poor, can we insert a NG tube? So we know that NG tube might help for him in the feeding, the nutrition part. It will also be a discomfort for Mr. Das. So we have to explain them in a manner which they could understand, that this will not give a cure, but it will again give a discomfort for the patient. So we are avoiding the insertion of NG tube. So here we mainly concentrate on the care aspect or the comfort aspect of the patient. Next is the non-maleficence. Non-maleficence means do not harm the patient. So here again we will avoid unnecessary harm for the patient. That is, we will not insert NG tube, or we will not give any IV fluids, or even if, though the Mr. Das is having secretions, we will not do suctions frequently, but if it is needed, only then we will go for that. So we will reduce the harm, pain, and suffering for the patient. The fourth principle is justice. So here, apart from the age and prognosis, though he is in a dying phase, in few days or weeks he is going to leave, or he is 80 years old, he is in an older age, the care that we give should be in a fair and equal manner. So we should not rush, or we should not rush in explaining the family members what we are doing. The conversation should be in a smooth manner. We should tell them, we should give them time and attention, so that family members will understand why we are not giving few cares and what we are trying to give. The comfort part they will also come to know. The fifth, veracity. So veracity means the duty to tell the truth. So the family members should be informed that he is going to die. So we have to communicate in a honest manner. We should not give them any false hope like he might improve. We should not give any false hope like that. So the conversation or the message which we deliver to the patient member should be in a balancing the sensitivity and time. We should compassionately deliver that message that he will be leaving us. And the last principle is fidelity. So though all these things are, we as a profession, we know what we are doing. The same thing, though the family members pressure, இது பண்ணல ஏன் அது பண்ணல அந்த மாதிரி they might ask, because they want somehow to revert him, or நம்ம கேர் பண்ணல அப்படிங்கிற தாட் அவங்களுக்கு கிடைக்கூடாது. So we have to do, or we have to advocate for the patient. So be responsible and a professional commitment should be in a faithful manner, so that the patient's family members will trust us and they will know, okay, if this nurse tells it is correct, or they will have a trustworthy relationship with the nurse. So these are the ethical principles which we need to follow while taking care of the patient in the last stage. So the principles are like autonomy, beneficence, non-maleficence, justice, veracity, and fidelity. Ma'am, the next slide, ma'am.
Yes, done.
So how we can explain to the family members is, they had asked, can we insert the NG tube? So here we can tell them what are the risks in inserting a NG tube. So first, it might cause discomfort for the patient. Then it will not prolong the life, and here again the secretion will be increased, so it is contraindicated for the goal of comfort. It will not give comfort for the patient, and then by inserting this will not create any hope of living. And then these are the things we can tell the members, and instead of that, what can be done is we can give periodically oral care for the patient. In The intake can be reduced. The oral intake reduction is normal in the last stage, and then we have to reassure the family. Here, the only thing we can do is the comfort measures and the symptomatic management. So, we all, as a team, as a palliative care team, we will be taking care of Mr. Das, and whatever we do will be documented. These are the nursing care what we will be doing, and while doing this, the ethical principles we have to follow. So to summarize the scenario and the topic, the first question was why the noisy breath arises. So it is nothing but we tell it as a rattle, death rattle, which is caused by the pooling of secretions, and cough reflex will be diminished. It is one of the active sign of dying phase. Next question was, as a nurse, what immediate action we will be doing? So here we will do all the measures which will be physical, which gives physical comfort for the patient, and then reassure the family, and we will be notifying the physician. As a holistic comfort nursing care, we will concentrate the physical, emotional, and the spiritual need of the patient as well as the family. So in all these phases, we have to maintain the dignity and respect for the patient and the family. Last, it was the ethical stance. So here we have to follow the non-maleficence, and we have to make the family members understand why we are not inserting the NG tube. So good end of life care is not about giving up, it is about choosing dignity. So to conclude, we have a video. So the video covers the scenario and the main points in the scenario.
This is Mr. X. He is 80 years old. He has completed chemotherapy and radiotherapy. He is now in the terminal phase of his illness. Observe carefully. Mr. X is sleeping for most of the day. He speaks only a few words and only sometimes. He sips just a teaspoon of water. He is becoming less responsive. These are signs of the dying phase. Comfort is now the main goal. Give gentle mouth care every 2 hours. Use a soft, wet swab to keep his lips and mouth moist. Do not force food or fluids. Change his position slowly, every 2 to 4 hours to prevent pressure sores. Keep his skin clean and dry. The family also needs your support. Speak softly and honestly. Tell them he can still hear your voice. Please talk to him. Hold his hand. Allow them to sit close. Answer their questions with kindness. This time is precious. Remember, in the terminal phase, our care shifts from cure to comfort. Watch the patient. Support the family. Be present. This is the heart of palliative nursing.
So end of life care is nothing but we shift the focus from the cure to the comfort part. So as a nursing mandate in this moment, Mr. Das deserves to die with dignity, free from pain, and surrounded by love, not surrounded by tubes and alarms. So the nurse's role is to make his final hours as peaceful as possible, to walk alongside his wife and family as they face one of the life's most profound moments. So from this scenario, how the teaching strategies can be followed are, we can have a group discussion. For the small group discussions can be maintained. So we can divide the team into 4 groups. So each group can concentrate on the one group can concentrate the physical care that is related to the pain and breathlessness. The second group can concentrate the psychological and emotional care. The third group for the family support and communication, and the fourth group regarding the ethical issues like DNR and autonomy. So they can prepare and we can all have a discussion on these topics. And the next based learning. So here in the mannequin, we can have a simulated dying patient. So in that we can set the symptoms like dyspnea, pain, and agitation. And the team can have the team will be having a healthcare roles and as well as a family member role, so that we can enact the team can enact in that we will be focusing on the crisis handling, how emotional response to be given, and in the debriefing stage we can tell what went all well and what could be improved. Next will be like, and the next strategy is problem based learning. So here we can we can tell what is the problem. We can read the scenario to the group, and from that student will be identifying what are the problems, what are the learning needs, and how we need to prioritize the care, and they will be using like a critical think, and they will be doing the nursing care. So these are the teaching strategies which can be followed by the students. So with this, we end the scenario. Ma'am, we give the session to you for your suggestions and discussion, ma'am.
Yes, it was very good presentation. So congratulations. First of all, hello, am I audible?
Yes, ma'am.
Okay, okay.
Yes, ma'am.
So yes, it was very clear. All the points were given and explained very nicely. I hope no one has any other problems with the understanding part, other team members. If there are, then you can put in the chat or you can unmute yourself and ask. Okay. I would like to add a few points here that many times patients are on polypharmacy, right? So at the end, we need to look into this matter also, that if the patient is taking too many drugs, only necessary drugs can be given. Okay, and as our patient has become unresponsive also, so many times he may require some subcutaneous injectables also, right? Only if required, right? Otherwise, most of the times what happens, patient is alone with the family members. Okay, so we can make them understand these things. Okay, many times for reducing the oral secretions, uh, atropine eye drops are also used sublingually. Okay, 2 to 3 drops are given sublingually, so that also may be useful to reduce the oral secretions. Right? Another thing, when you said that you can make the patient little higher the head end, okay, but we also need to see that he doesn't flip over, right? Because the patient is unresponsive and they will be quite in sleepy, right? So that care should be taken. Okay, so whichever position is comfortable, that can be given, and for removing the secretions from the mouth, they can turn the face on one side. Okay, so because in the end, high up position may not be possible, okay, to manage. So that one. Then as the patient may have incontinence, right? So most of the times nowadays, patients are put on diapers, right? But many times in changing the diaper also, patient becomes agitated. Hmm? They said that no, I have not passed urine, like that. But then we have to tell the relatives that gently just divert his mind, or any patient for that matter, the mind, talk softly and see to it that the diaper is not full of urine or stool. So that skin care should be taken care of, and applying of moisturizer, or even we don't use though talcum powder, but sometimes it may become necessary when there is lot of perspiration, or if there is any sign of fungal infection. Okay? So we never know when the end will come, right? So that needs to be addressed. uh, Pain, of course, you covered it very nicely. Then yes, there is another thing is also there, psychological, that as the patient is male, he may be the uh, family head, right? So now the uh, family head will change, isn't it?
Yes.
Mother, I mean, Mrs. Das may be the family head,
Yes.
or the children, whether they have son or whoever, right? So there may be the role reversal, right? So that also need to be addressed. And wife will be naturally very psychologically very upset. So psychological care, talking with the carer and all that, because so many, since so long she might have taken good care, right? So acknowledge her care, that is also important. Okay, that you had given good care, so the Mr. Das survived so long, and all sorts of things. Okay, so psychological empathy is also required. Then many times the patient may the upper body will be more warm and feet will be cool, right? That is what happens. Sometimes there may be like fever like symptom also when the person stops drinking fluids and all that. Okay, so we need to check for the body temperature, maybe by, I mean, back of dorsal part of the hand and like that, right? So that can be checked and necessary care can be given. Uh, okay. Yes, and there should not be any hush hush talking in the room. Okay, so that also you had covered very nicely. So, and calling of other family members if they want to see the person in their last days. Okay, so that is there. Sometimes nowadays technologies are also available, so video call and like that also can happen. Reading of religious books can also be done. Uh, Prayer, of course, you had mentioned, so that was very nice. And when there would be only the caretaker or only family members present at the last moments, right? So, what to do, from where they can get the death certificate, who will declare, all those things. Okay. Then the patient may have expressed his will, what he wants to do with his body. Okay, so regarding that also one needs to, so any kind of advanced directives, not only the emergency, I mean DNR and all that, but about the body also should be taken care of. Okay, so these things are also important. That's all from my point. Uh, so all you have done the presentation wonderfully. So congrats once again. Yes, anyone wants to discuss anything?
Thank you for the wonderful presentation. Thank you, Anna, for the wonderful facilitation. Anybody have any points to add?
Yes, and covering of eyes. Sometimes eyes remain open when they are sleeping. So just like the care we are giving to lips, don't forget the eyes.
Yes.
So always remember when the patient is in the end of life, so the caregiver usually request you to put an artificial feed, right, rice to feed or intravenous infusion, whatever it is. So why they are requesting to give a artificial feed? It's because of the love, no? So food is a symbol of love. So they are requesting you to put some artificial feed. So what we have to understand is you have to uh, understand their concerns also. You have to respect their concerns. Why they are requesting you to put a rice stove? So we have to respect their concerns and elicit their emotions also. Then if you sit down and listen their concern, they might have lot of things can tell you. So you just to listen their concerns, and based on that you can able to, as you discussed earlier, you can able to convey this that benefits and that maybe what all things is good and what all these things is bad for that patient. So that patients, the relatives might be understand well, and so they will follow your instructions. Otherwise, they frequently request you to put a rice to or a intravenous infusion like that. So always remember, our intention is in the end of life care is make the patient's dying process is easier to the patients. At the same time, you have to give a psychological support to the patient family also. Okay, so they are going to lose their loved ones. So you have to give a good psychological support to the patient relatives also. So you have to convey these things to the children. Okay. And don't forget about the children's also. If there is a children's there, you have to include the children's also. What they are, what is happening their parents. So you try to include the children's also in the patient care, especially in the end of life care situation. Thank you.
Thank you, ma'am.
So this is your last session. So I would like to know your feedback and suggestions. If you want to give any suggestions for improvement, please give your suggestions also. So we would like to hear your feedbacks. Anybody?
Ma'am, thank you for arranging a great course, and all the sessions was very nice, ma'am. And you have made us to do some presentation, which will not be in all the courses. So thank you for the opportunity you have given to us. Thank you, ma'am.
Thank you.
Ma'am, most of the people are responding in chat box. It's an excellent section, Bolke.
Yes, yes. I saw.
Actually, I'm out, ma'am. It is kind of. I will call you back. I mean, I will respond within 5 minutes. I'm outside. I'll be reached in 2 minutes. Is that okay, ma'am?
Yeah, yeah.
Because the noise is there. That's why.
Okay. Anybody else?
So Shiva ma'am, if there is no feedback, we can just thank to the faculty and facilitator
Yes,
for
yes.
taking the session, and we can just wind up the session, ma'am.
Yeah, yes, yes.
Yeah. So thank you, Miss Anna Daniel ma'am, to facilitate the session, and Mr. Abhishek and Mrs. Gloria to faculty to be the faculty for the session. And it was such an amazing, excellent presentation. And thank you, Shiba ma'am. And I would like to take a moment to thank for you that for the patience and the facilitating the India session. Thank you, Shiba ma'am. So you can share the feedback from your side also, ma'am.
Yeah. So once again, thank you for being with us. I would like to tell you one thing because now you have learned about the total pain concept, right? So why this faculty development program is that is 20-hour palliative care module is added in the BSc nursing curriculum. So now you have learned about the importance of total pain concept. So wherever you teach or whenever possible, please convey the total pain concept to the nursing students so that they will understand well, and they'll get, if they get times, they will maybe they'll sit down the patients and side and listen their emotions also. Because if they have a psychosocial issues there, their physical their distress intensity will increase. So wherever possible, they have to go to the patient side and listen the patients and families worries and problems, so that we can able to improve the quality of life. So all other points you have to keep it in mind. So we are trying to give a symptomatic management to the patients and the family. So if we are able to control their symptoms, definitely we can able to improve the quality of life of the patient and their family. So always you have to keep it in mind. Whatever you have learned from this faculty development program, so please convey these important things to the nursing students also, so that they can also include this palliative care concept whenever they will be in the patient care. So all the best. If you have any doubts, any problems, please let us know. Please put your questions or any things in the WhatsApp group, so that we can able to help you. And wherever you go, please convey this palliative care concept. Thank you. Or thank you, Anna. Anna, anything you want to
Thank
add?
you so much. No, thank you very much for this wonderful opportunity. And I wish all the best to the new batch. I remember once I was also part of such batch. So it
Okay.
was very nice.
Thank
Thank you
you.
so much. Thank you.
Thank you. Thank you all.
So, thank you. Dear participants, kindly submit your all of the assignments that. So once you are submitting the assignment only, you are eligible. You will be eligible for the certification. So, and all the learning materials and the video link I have uploaded on at Ayako app. If you are facing any issues, you can just reach out to me directly. I will lead you how to open those things. And thank you. All the best for the future, and all the best for you guys.
Okay. Thank you, Hannah.
Ma'am, shall we wind up the session?
Yes, yes. We can wind up. Thank you, Hannah, especially for the wonderful coordination. Thank you.
Thank you, ma'am. I'm really sorry. I'm in a hurry, so
No,
really
no
sorry.
issue, no
Yeah,
issue, no issue. Thank
yeah.
you. Bye, bye.